Thank you for joining our Primary Care Innovations webinar series. It's supported by the H. James Free Center for Primary Care Education and Innovation. Before we get started with today's presentation, there are a few housekeeping items. So number one, please mute your audio during the presentation. We will be recording the session for future viewing. So please turn off your video if you don't want to be included on the video recording. Second, please type questions using the chat function on Zoom. At the end of the presentation, I will lead a Q&A session. And during the Q&A session, if you would like to speak, please feel free at the end to use the raise hand feature if you need to, or you can type your question. Number three, to claim 1 hour of CME credit for the session, please complete the evaluation of the session at the end of the webinar. So I'm Maury Stern. Today I am thrilled to have Dr. Applebaum and Dr. Kasseri from Florida State University College of Medicine, and they're going to be presenting Trans Health, a success story in a residency clinic. Dr. Applebaum is an internist, geriatrician, and an HIV expert. He currently holds the Laurie L. Dozier Jr. MD Education Director and Professor of Internal Medicine at Florida State University College of Medicine, and he also serves as the chair of the Department of Clinical Sciences. He's spoken on or has been a number of panels on topics such as health issues in the older LGBT patient, HIV and aging, and the LGBTQ curricula in undergraduate medical education. And Dr. Applebaum is on the faculty of the FSU Tallahassee Memorial Healthcare Internal Medicine Residency Program. His interests focus on LGBT health disparities and aging and HIV. Dr. Ramiz Kasseri is a dually board-certified internist and pediatrician. He earned his medical degree from Michigan State University, College of Human Medicine, and completed his residency training at Beaumont Health. While in residency, he held the position of Program Committee Chair for the LGBT Employee Resource Group, which covered all 7 hospitals of the Beaumont Healthcare Network. He worked on projects to place preferred pronouns and names in the electronic medical records, provided a comprehensive list of LGBT-friendly providers, and secured sponsorship for all of the Pride events in the Metro Detroit area. He's most recently served as the chief resident for internal medicine residency program at Tallahassee Memorial Healthcare for FSU College of Medicine during this last academic year. He continues to be interested in the underserved LGBT populations and hopes to focus more on adolescent health in the future. So thank you for sharing your innovations today. Please feel free to start when you're ready.
Awesome. Hello. Hi, I'm Ramiz Kasseri, and thank you for that great introduction. Before we get started, I just wanted to run through what the discussion is going to be like today to kind of give you an idea of what we're going to hit on. So as you mentioned, we are involved in providing LGBT care and have done so recently in the Tallahassee area. So the first thing we'll talk about is discuss how did this start, what was the first step in that kind of journey. And then after we set the stage of how we started, then we'll talk about topics that come up that both John and I have experienced with our patients that they ask. Then we'll also touch upon the challenges that have been faced in terms of having a successful clinic. And then at the end, we'll finish up with what were the keys to the success of this clinic, or for anyone who's interested in having clinic, what kind of would be words of wisdom. So without further ado, we'll start with Dr. Applebaum. So tell us about how this all started.
Thanks, Dr. Kasseri, and thanks for you folks down in Gainesville for asking us to talk about what we've done here. So this really started, so first of all, our residency program started in 2012, and that's when I became involved with the folks over at Tallahassee Memorial. And around that time, we started hearing from members of the trans community here in Tallahassee about the difficulties they had in accessing primary health care, and in particular, accessing gender-affirming hormones. And as I sort of delved into this a little bit more, I heard that access to the gender-affirming hormones was pretty much limited to, 1 or 2 endocrinologists in town who for various reasons, and I think I can enumerate some of them, but it was really that they sort of had reached their limit of the number of new trans patients that they could care for. And so I was approached by some people from the community about whether or not we would perhaps fill that role. My experience prior to coming into Tallahassee, I had worked at a LGBT health center where I, kind of learned how to care for trans patients and felt pretty comfortable with, evaluating and managing gender affirming hormones. So this really grew out of a perceived and real disparities in obtaining good healthcare for this population. And so through that, we started getting some patients. One of the first patients that we started to see was someone who is quite prominent in the trans community here in Tallahassee. Actually, yes. She usually emcees the annual Pride Fest programs. And it's obviously she has a lot of connections in the community, and so that's how you build a practice. One person likes what you're doing, they think you're appropriate and friendly and welcoming and affirming, and so that's how the word spread. And the other piece I think that's important is, as a member of the LGBT community, I reached out to other members of the LGBTQ community. I was invited to talk on LGBT health in general, and in fact, was also invited to one of the transgender support groups here in Tallahassee. So those are, I think, things that are really important. If you are a member of the community, but even if you're not a member of the community, to reach out to the community, to let them know that you're supportive, that you want to be an ally.
Mm-hmm. I think that this is paramount, because one of the things that I have seen, or the conversation that I've been involved in, is some providers are just kind of maybe hesitant about providing care, hesitant about being an ally. And the example that I give is diabetes, is that as a physician, I don't need to have diabetes in order to treat diabetes. Therefore, part of our profession is learning about things that we know very little about, and engage in the community and seeing how we can show up to the community in a meaningful way. And that kind of community outreach is how I previously have done it in Michigan, but even here. And within our patient population in the clinic, it always was great when they say like, oh, Dr. So-and-so, you see one of my friends and they told me about you. And that kind of, the power of the word of mouth is very, very important. So a couple of things that we wanted to talk about. So within the context of a residency program, how does that work? How do you kind of start having a robust transgender clinic?
Yeah, so I think we made the decision right off the bat that we wanted to integrate trans care, actually an LGBTQ care, into primary care, not segregate it. And the model I think that we followed was the same thing what we're doing with HIV care, which is we didn't have an HIV clinic. We had HIV patients who were scheduled, like any other primary care patient. I think the issues that we found were, number one is I was the only quote unquote expert, okay, and the residents really came with some actually had some experience and felt comfortable, but I would say a majority of the residents, and it didn't matter whether they're PGY1 or PGY3, some of them felt uncomfortable because they'd never really had the training in LGBT care as an undergraduate, which is a whole nother issue about medical education. So, I think we had a couple of things we had to overcome. Number one, faculty development. Because I was just one of many preceptors, and my time at the clinic at that time was 3 half-days a week. I was doing 3 half-days a week back then. So there was quite a lot of time when I wasn't available or I wasn't there. And then the other thing obviously was resident education. So we had sort of 2 things that we needed to address. I think the first piece, the faculty development, I think we approached it a couple of ways. Number one, I made myself available, through email or even texting, if patients were there and the preceptor had questions when I wasn't available. And that was not, we didn't have that large of a population that it was overwhelming for me. And then and then we actually did some faculty development sessions. Some of the faculty participated and some didn't. It wasn't a mandatory session. But again, then at that point, you had more than one person who felt comfortable. And we also provided resources, and we can talk about that later on, what resources are available online. And then the other piece was around the residents, and so I developed a Transgender 101 noon conference, which I think we try to do every year. We didn't always succeed in doing it every year because we wanted to make sure that the new PGY1 interns who were going to be seeing these patients in clinic felt comfortable, but also as a refresher to the PGY2 and PGY3 residents to kind of make sure that they were up to date on cutting edge treatment. So I mean, that's kind of our approach.
And on the receiving end of John, because I was one of the faculty that I reached out to him and I learned from him, one of the problems in my own residency training is that I saw no transgender patients at all. And this goes back to the issue you were talking about in medical education. That was just not part of the curriculum that we had. So when I started my job as a chief, we had a robust transgender clinic, and that forced me into a very, quick learning curve in order to provide care. And you kind of just have to tackle it like that. It's a skill that you develop, but honestly, it's not rocket science. You read about it, you learn about it, you see the first patient, you see the second patient. What I think is most important, and at least from what I've seen from taking care of LGBT patients, is treating patients with respect and dignity. And when you don't know something, it's fine to say that, I'm not very well aware of this. And I've actually done this with some of our patients where I said, I will need to talk to Dr. Applebaum, and then I will get back to you so that we can figure that out. Having that kind of approach, the patient appreciated. They knew that I wasn't deflecting or was trying not to provide care, but I don't have all the answers. And at the end of the day, we're not endocrinologists. We are doing this as part of primary care. So there's always more to learn when it comes to that. And by the end of the year, I would say that we were pretty successful in seeing trans patients pretty much every day of the week.
Yeah, no, and I think that was one of our goals was we didn't want it, as I said earlier, we didn't want to turn this,
Right.
My clinic days are going to be transgender days. No, we wanted every one of the residents to have at least a couple of transgender patients so that they would feel comfortable, which kind of gets me to the point. Do you want to share with them our numbers, kind of what
Sure.
population you're
Right.
talking about?
So one of the things that we wanted to look at was how are we doing in this clinic, because it's been 4 years, I would say about 4 years effectively of having a quote unquote a transgender clinic. And the numbers were great. They were not stellar, but they were great because every year we notice that we are seeing more and more patients. And not only were we seeing more patients, we were retaining more patients, which was the big deal. Now, when you look at the raw numbers, maybe they're not like huge in the thousands, but the point is something was working well enough year after year that the patient population was growing and the retention rate was getting higher. On top of it, the range of age of patients we were seeing was also getting bigger. So the clinic is in a college town, so sometimes you tend to see more of the younger folks that come, and then for however many years and then they leave. But then we noticed, no, there was not just the college age, it was kind of variety of spectrum, and it was a variety of spectrum of trans men and women, which was also a big deal. Okay. So we're going to talk about more of the challenges you faced in a minute, but something that I think that comes up quite a bit in patient discussions is certain topics. So I want to touch on some of those and get your thoughts. So I'm just going to run through this list. One of the things that we asked a lot about is birth control. So can you talk a little bit more about that?
Actually, I'm gonna step back. Well, actually, we're gonna talk about fertility later on. Okay, so we won't talk about fertility right now. But so I think people need to understand that particularly for trans men, so I'm talking about folks that were biologically or born as a female and are now have transitioned into male. One of the things we tell our patients is that early on, probably within 3 months after starting testosterone therapy, their menses should begin to become irregular and probably stop within 6 months. But, and this is a big but, is that they also need to be counseled that they still have a risk of becoming pregnant. Mm-hmm. So this is where we, if they're in a relationship where there's a potential that they could become pregnant, that they need to be using adequate contraception. So that's a key piece there. And that's, as I said, particularly or mostly for trans men.
Mm-hmm. Now, I think we'll talk about it a little bit more later, but some of the questions that I got was in terms of overlapping, the flip side of that, of estrogen and birth control.
Okay, so you mean as far as the actual hormones?
Mm-hmm.
Yeah, so so for trans women, folks who were born as male and are transitioned or have transitioned into a woman, we don't use birth control pills. Mm-hmm. So you're not going to prescribe them a birth control pill. And the reason being is that the primary estrogen formulation in that ethinyl estradiol is actually a pretty potent estrogen. We use the pure synthetic estradiol, the natural hormone, which is available relatively inexpensive. And it's a single hormone. Remember, a lot of the oral contraceptions are combinations of progesterone, mm-hmm. progesterone and estrogen. So we want to use the pure estrogen.
Last follow-up question, because we're still on birth control, is that there are certain times where someone is interested in starting testosterone, but remaining on birth control for a certain period of time until they get an IUD or whatever the case is. What kind of recommendation do you give those folks?
Yeah, so those folks certainly, the injectable Provera is certainly mm-hmm. Perfectly reasonable. There are people, I mean, this hasn't come up a lot in my practice, but there are people that will leave them on, mm-hmm. Oral contraceptives while they're transitioning. I think if you're going to use a hormonal contraceptive, I think the progesterone injectable is probably the better one. Obviously, other non-hormonal things, IUDs, right. Barrier methods are mm-hmm. certainly also reasonable.
Another topic that comes up quite a bit: name and gender marker changes.
Yeah, that comes up all the time. I was the king of the letter writers. So you have to write letters for patients who are trying to get their gender markers changed, be it through the Department of Motor Vehicles or through Social Security to have their Social Security information changed, or passport. And there was another one. There's another. I'm trying to think. There was a Social Security, passport, driver's license. There's another one that's another separate letter that you have to write. And the key here is that it doesn't have to be just one person. Any licensed physician. We didn't allow our residents to write these letters, but because they have a temporary license. but any one of the faculty could write a letter. There are specific formats, and there are actually form letters you can actually download, and that's exactly what we did. We basically downloaded them on our letterhead, and we just filled them out. One of the things that we found, again, I don't know if it's true down in Gainesville, but here in Tallahassee, for the Department of Motor Vehicles, they required that the letters be notarized. So even though it was my signature on my letterhead, we still had to have my signature notarized. So that's just a key challenge that we found. It was a little bit of a barrier. Luckily, we had someone in the residency office that was a notary.
And I think when it comes to that, it has been my experience of setting the expectation is a big deal. So really, talking to the patient that you cannot ask for the letter the day of when something is due, because this takes some time. And if you have a robust clinic, then you have, a mountain of paperwork that you have to get through anyway.
Right.
So setting the expectation is a big deal. And that will segue into something we'll talk about a little bit later. One of the topics that recently have come up, which is kind of important, I don't want to call it new because it's not really new, but it's gotten more exposure recently, the idea of gender queer and what that means. Can you talk a little bit more about that?
So I'm assuming that folks on the call understand the model of gender is not binary, so it's not male, either male or female, that it's really more of a continuum. And there are people that don't feel that they identify with either male or female, that they're maybe somewhere in between. And there's a lot of different terms for that. And the one that, at least that folks tend to use here in Tallahassee, is gender queer. And what does that mean, and what does that have to do with what we're talking about today? So if these are folks that are either biologically born as a male or a female and feel that they're gender queer, they want to have less of the characteristics of the sex that they were born with, yet they don't want to fully transition to the exact opposite sex. So for, let's say for male to female, what we have done and what other people do, this is not just us, but what other people do is, rather than starting them on estradiol, what we will do is use a androgen blocker first, which kind of tends to mute or soften the androgen effects, yet not make the person fully feminine or female. It works on some patients. Sometimes this is, I think of this as more of a transition. They themselves are transitioning. They're not quite ready to actually take female hormones, but over time, often they'll make that decision, and then you just place them on the estradiol. So the androgen blocker that we tend to use is spironolactone. You have to watch when you use that because it's a diuretic. We always get a little concerned here in Florida where it's really hot and humid and people may not be drinking enough water, so you always counsel patients on that. The other side effect of that is it can cause hyperkalemia, so you have to monitor potassium levels on these patients. My approach is always, as a geriatrician, to start low and go slow. So I always start at a low dose and work with the patient to see if they're getting the desired effect, and then increase the dose as needed.
And I think this in general as a topic is a product of the time, because now we're having more conversation about non-binary folks, gender non-conforming, and I don't think in recent history that we've had this much space in the conversation about things outside of the mold, because for the longest time it was like, you're either this, or that.
Right.
And now the conversation is truly about how a lot of these things can be fluid, and you can exist in a space that doesn't put you in a box. And we obviously respect that when the patient brings that forth.
Right.
Can you talk to us a little bit about how we do this in terms of the process of informed consent and how we get the ground running when we see a patient?
Sure. Early on, we made the decision that we were going to approach this using the informed consent model. What does that mean? Well, informed consent is you discuss with the patient, have a dialogue, you review the risks and benefits in the process, and if they're competent to make medical decisions about their body, they give you informed consent. We do this all the time. Why is that surprising, or why is this different? Well, it wasn't that long ago when doctors, and not just primary care doctors, I'm talking about even endocrinologists, put all kinds of barriers in front of transgender patients that they had to walk through or jump over in order to get access to gender affirming hormones. Barriers such as, requiring them to live in the habit or the clothing of the sex that they wanted to transition to, having to be under the care of a psychiatrist for X number of months or years, and or a therapist, sometimes having multiple psychiatrists. There were all kinds of barriers out there. The informed consent model is really a model of, you evaluate the patient, you decide whether in fact they are gender dysphoric. I hate that term, but that's the term that the psychiatrists use. And if they understand the risks and benefits of gender affirming hormones, then you can go ahead and proceed.
Can you comment a little bit more, because I know this is a big misconception about the need for the letter?
Oh, okay, yeah. So in the old days, many clinicians required 1, 2, or 3 letters from mental health practitioners to basically rubber stamp that this person was in fact transgender. We don't require that, although I will tell you it's nice to have a letter. I always like to know, in fact, that this is a person who has, even though they've struggled with their gender identity, they've sought behavioral counseling over the years. We've developed a very, I think, pretty close relationship with several of the mental health practitioners in the Tallahassee area. In fact, some of them have referred, in fact, many of them have referred patients to us for gender affirming hormone therapy. So working with these folks is usually pretty easy for them to say, yeah, I saw this patient, I've been seeing this patient for 6 months. I fully agree with their desire to transition. So we ask for that letter. We don't demand that letter. Now, there are some times, and I'll kind of get into the other end, where when people come in, we don't automatically give them hormones because they want hormones. There are patients that we've had our concerns about. And I think patients who have really significant underlying mental health disorders, and I'm talking about, schizophrenia or schizoaffective disorder, borderline personality, really significant psychiatric diagnoses, and they're not under the care of a mental health practitioner. Those folks, I will talk to them and basically say, I don't feel comfortable doing this. I think I need to get some input. I'd like you to seek a consultation.
100%. Yes. And that the flip side of that is that where I seen care being halted is when someone who has seen care for 4 to 5 years, they're new to town, they have the records of their care, but some providers will still, well, I need a mental health provider to say the X, Y, and Z. And we, I guess, both can agree that that is not necessary if it's not indicated for.
Right.
You almost touched on it and kind of backed out. So let's talk a little bit more about fertility.
Okay, so fertility is a big thing. It's something I stress when I'm doing my informed consent with the patient. By the way, we have an informed consent paper. Remember, informed consent is not having the patient sign the paper. It's actually having a dialogue with a patient letting them ask questions, you asking them, like, teach back to see whether they in fact understand what you're talking about. So one of the key features during my discussion of any patient who is requesting gender-affirming hormone treatment is an issue around fertility. As Ram has said before, we're in a college town, so we have a fair number of younger patients who are still in their prime when they might consider having children. The thing that you have to stress to them is that when they begin taking gender-affirming hormones, their fertility will decrease and may, in fact, end. So they need to think, and again, these are young people who sometimes don't think far ahead, that in fact, they may want to preserve either sperm or oocytes for the future. And so that's something that we counsel them on, and it's the reason why one of the reasons why we don't give them hormones the first day that they come in. It's a process, and they have to decide, in fact, whether they want to proceed with sperm banking or egg donation. The problem here in Tallahassee is we don't provide either one of those services. So patients need to do a little research and go elsewhere to have that done.
And we'll touch a little bit more on that later when we're talking about what challenges we have faced, because it's easy to talk about LGBT care in a big city, Chicago, New York, bigger cities, but when you come to smaller communities, you might have access to some things and you just don't have access to other. And that's just the reality of geographically where we are right now. The next topic is, I think, to me, is one of the most important ones, because there is sometimes misconceptions when the patients come in, and I often have to preface, what does treatment involve? What are we doing? What to expect? So can you talk a little bit more about the expectations and how to navigate that conversation with patients?
Yeah, and a lot of this is actually on our informed consent document, and that's why we always have the patient read it, take it home with them before they begin hormone therapy. So one of the big things for our trans women is breast development. And I tell them that with estrogen, they will develop breasts. However, the size of the breast, in my experience, is not estrogen dependent. A lot of it is genetics. If they come from a family that is large breasted, they will develop large breasts. I still remember one of my very first patients, after a couple of months on a relatively low dose of estrogen, was wearing a B-size bra. And I was very surprised. But then in talking to her, her mother was large breasted. And other folks, if they come from a family where the breasts are not very large, they're not going to develop large breasts.
So can you then talk about, because you mentioned estrogen, and that segues also to spironolactone, can you talk about the idea behind, well, if I get a higher dose, then the effect will be better, and then the addition or doing spironolactone concurrently?
Yeah, I mean, there is some increased benefit to estradiol by increasing the dose. When we try to maintain the dose between 4 and 8 milligrams a day, which is what the standards are, and we'll talk before we leave of some of the standard of care documents. But we try to go for that between 4 and 8. Going higher is not going to make anyone more feminine, and in fact increases the potential for side effects and risks. Spironolactone, which is the anti-androgen, blocks the peripheral conversion the peripheral conversion into testosterone. But there are some data that actually suggests that spironolactone may have a antagonistic effect with estradiol. So my approach is to begin estradiol first before I begin the androgen blocker. And I will only use the androgen blocker if I feel like there's some androgen effects that we're not able to eliminate by a higher dose of estradiol. So I tend to go higher estradiol and probably lower doses of the spironolactone, only because of that data that would suggest that.
Would you, because I've also experienced with some patient, is that they come in, quote unquote, well-read, and they want to initiate both at the same time.
Again, I'm coming from my geriatric background where we don't ever want to start two drugs at the same time.
Sure.
Even drugs with well-known effects and side effects as spironolactone and estradiol, if there's a problem, then which drug was causing the problem? That's
Sure.
sort of my background.
Sure.
So that's just my approach.
Okay. Can you talk a little bit more about the question mark benefits of progesterone?
Yeah, I mean, that's controversial, although I think the experts in this field that I talk to and I respect really downplay the benefit of progesterone. There's a lot of urban myths out there about the benefit of progesterone. The downside from our perspective is that it certainly increases the risk of potentially bad side effects.
Right.
But the urban myths out there is that it causes more feminine deposition of adipose tissue, and that it increases the size of the breasts.
Which is why we haven't used it.
Right, right.
And the last part in terms of the category of talking about treatment is, I've seen this question come up time and time again. There's this idea for some patient that if they do injectable, they get a better result than oral.
Yeah, no data support that. Oral estradiol, very well tolerated, very well absorbed, very cheap. The injectable estrogens at times have been hard to come by. And there's no data that I've seen that they're better absorbed or do any better job than the orals. I think the mystique about injectable estrogen is because the trans men get injectable testosterone, so they think it's got to be the injection that helps.
Yeah.
But estradiol, there's no reason why you can't use regular oral estradiol.
And then the last topic that comes up is tobacco use. Can you talk a little bit more about that in terms of where the concern is?
Yeah, so this is the other soapbox I get on. So I talk to my patients, as I mentioned before, a lot about fertility, but the other piece is cigarette smoking, because there's a exponential increased risk of venous thromboembolism in trans women who take estrogen and smoke cigarettes. So I tell them that they really need to do everything they can to stop smoking. I also know that there are some other practitioners out there that actually will not prescribe estrogen until the patient stops smoking. So we do everything we can to get them to stop.
So this kind of covered a lot of the topics that we often see in the clinic and that come up during the question segment towards the end. Feel free to ask us more about things you're wondering about or things patients may have asked you about. The next thing where we wanted to touch on is in having clinic that caters to the LGBT community, but more specifically the transgender community, we have had some hiccups and challenges. So we wanted to touch a little bit on that. Let's start with the first topic, which I think is important, using proper pronouns in every step and in medical record.
Yeah.
I think I have a little bit more of a patient view experience because my office is right in front of the registration for patients. So I often hear the conversation that goes around between the patient coming in and the front desk person.
Okay.
And sometimes it's not as great as you want it to be.
Yeah, so I think that's the important thing. You can do everything. You can be the best clinician, the most patient-centered, the most affirming. Yet if your front desk staff isn't, your whole practice is trashed,
Right.
as far as I'm concerned. And I've said this all along, that we never pay our front desk staff or the folks that answer our phone enough, because they can either make or break your practice.
Absolutely.
We talked about faculty development, resident development. Your staff needs to be trained also,
Mhm.
and they need to understand this. You mentioned about proper pronouns. I will always, one of the first questions after I introduce myself to a new patient is I'll ask them, what pronoun would you prefer? And we try to note that in the chart. We've had some challenges with our electronic health record.
Mhm.
I don't know if you want to elaborate on that.
So one of the things the reason I have the information about our clinic is you have the ability when you're registering a patient to put the gender markers, but more often than not, they are not placed, which unfortunately that's what leads to using the improper pronoun. So recently I have gone through 4 years worth of transgender patients and looked at every encounter and aligned the proper pronouns for the patient, and that's how I was able to see like we're doing such a good job and we're adding more and more patients. I think for providers, depending on where you're working when it comes to pronouns, I know that some non-binary folks maybe feel that they shouldn't feel the need to disclose what their pronouns are, and I think I acknowledge and respect that point of view, but and there is no but, because that is a valid point, period. In working with patients day in and day out, where we are right now geographically, I think for a provider makes a difference. If we're in a very progressive area, very LGBT friendly, then we can elevate the care to the next level where those things are not necessarily have to be solicited in such a frank way. But for us here, when we're trying to tackle an area where we're pretty much the focus of LGBT care, we ask those questions to put the patient at ease. Like, we want to respect you, we want to respect the pronouns that you come with, and that's why we ask them.
I mean, one of the nice things about our electronic health record in the clinic is that we have the ability to put an alias on the banner.
Right.
So if the person is Joe Smith, but they prefer to be called Josie, we can put that in there.
Right.
We, and this is going to be a problem or an issue no matter where you practice, you can't legally change their name until in their medical record until they have gone through the process of getting their gender and name change legally.
Couple of things how about this? I will tell you what topics we can talk about because we want to make sure that we have enough time for folks to ask questions, but those are some of the issues that we come across. So we talked about faculty and resident development. We do run into sometimes religious and cultural obstacles, which are, I think, pretty much universal. This is sometimes a sensitive topic, and that bears with it the issue of acceptance, conversation, knowledge.
Are you talking about religious, cultural obstacles with providers?
With providers and with patients.
Oh, okay.
Because some providers don't feel comfortable from my religious doesn't.
Right, and we've had to deal with that. And so what we've done is we've just not assigned transgender patients to those residents.
Yeah.
It doesn't happen very often, but it does.
Insurance is another challenge, but in recent time, I've seen that is getting better and better.
More and more insurance are covering at least medical treatment. And we haven't even gotten into the surgical issues. That could be a whole nother discussion. Some insurances will not cover any gender affirming surgery.
Mm-hmm. The other thing is the knowledge gap, and I think that circles back to what I was saying in the beginning, is that there seems sometimes from providers a big level of intimidation. I don't know how to do this. And having the workshop that John had with Transgender 101 and slowly adding onto your knowledge is kind of how you bridge that gap. Do you want to talk a little
And,
bit?
and mentorship and,
And-
and preceptorship. So I think, it's kind of thing like anything. The more you see, the more you do, the more comfortable you're going to be doing it.
Right. Do you want to talk quickly about state lines, because we deal with this at least here?
Yeah, we deal with that here because we're, 20 miles from the Georgia border. You guys probably in Gainesville don't, but we have issues around insurance crossing state lines,
Mhm.
particularly the Medicaid insurances. Trying to think, prescriptions. That's another issue because testosterone is a Schedule III drug. Luckily, if they're from one of the communities that's relatively close to Tallahassee, that is not an issue. We have gotten patients from further away, in which case it's sometimes difficult to do the testosterone. We may have to actually do a printed or written prescription rather than transmitting it electronically.
And then I guess we can talk about the standard of care when it comes to the keys of success. We kind of wanted to wrap everything up to kind of leave you with a couple of points that we view are important points in terms of how can you have a successful clinic.
So a champion. I think I played that role, but it doesn't have to be someone who's an expertise in that. I'll give you another example. It's a little different, but it's here at the medical school. I'm the champion for ultrasound, point of care ultrasound. I was trained before ultrasound. I don't know that much about ultrasound, but I'm the champion for ultrasound. And people look up to me as the person who's trying to get this pushed through our curriculum. So you don't have to be the expert to be the champion. I think those are two different, they can be two different people. You just have to be someone who feels very strongly that this is something that we need to do.
Yeah. Community outreach.
I think we talked about that.
That
It's important to reach out to this community. This is an underserved, marginalized community. All you need to get your foot in the door is one person. So if you know one person in the community, the word will spread. And if they know that you're interested in providing access to good standard care, they will come.
The next point, which I think is very important, is that if you don't have faculty that's willing to learn and engage, it's a moot point because you can have all the faculty development in the world, but engagement is how you ultimately get something off the ground. So making sure that you recruit folks that will be willing to be invested in this process.
Yeah, and I think like anything, the engagement will come if the leadership pushes it.
100%.
So if the leadership is on board with this, the person who signs their paycheck or signs their contract, it will happen. If the leadership is not on board, then you may be spinning your wheels, kind of. Yeah.
The last 2 points can be combined together in terms of the couple of sources that Dr. Applebaum is going to talk about in terms of where you can seek information. That's where you keep up with the standard of care, and that's where you provide to yourself, to the other faculty, and sometimes to the patient information in terms of what is the most recent evidence-based medicine when it comes to transgender care. So keeping up with that would probably be.
Yeah, no, I think, and the good thing is that all these things are now available, or pretty much available online. So there are guidelines. This is not shooting in the dark. There are well-respected guidelines on caring for transgender patients. And I'll just mention three. I'll mention three and I'll mention some other sources. So the Endocrine Society has a set of guidelines. So these are the endocrinologists worldwide have come up with a set of guidelines. The World Professional Association for Transgender Health, or WPATH, was I think the first organization of health professionals worldwide that came out with transgender health guidelines. They're a great organization. My only concern about their guidelines is that they're now about 9 years old. They're in the process of updating them, but they're probably not the most current. I'll tell you, my go-to source is the University of California at San Francisco. If you Google transgender
UCSF.
UCSF Transgender Health, you'll come up with a phenomenal website that tells you everything we talked about in 100 times more details.
Mhm.
Everything you want to know about how to care for, how to manage, care for, evaluate, whatever a transgender person is on that website. The informed consent forms that we use were actually downloaded from that website. They talk about hormones, they talk about dosages, they talk about complication. They go through everything. So, and that is a web-based resource that's constantly updated, and it's evidence-based. There are journal articles that are referenced there. There are other sources too. Many of the LGBT health centers across the country have their own guidelines. So Howard Brown in Chicago, the Lesbian and Gay Center in Los Angeles, and Fenway in Boston all have their own guidelines, which are published. So there are lots of resources and sources out there for you to answer any questions. If I ever have a question, I go right to one of those sources.
And the last remark we'll leave you guys with before we open it up for question is within our own clinic, one of the key to success was having a diverse group of people, faculty and resident alike, that give representation to different parts of the LGBT community, different backgrounds, different races. That's how we were able to elevate the clinic to what it was in terms of being able to kind of align and understand and provide care to all members of the LGBT community, regardless of what the intersectionality they had based on religion, race, or what have you.
Yep, how true.
Okay,
Okay,
questions?
we have what, about 9 minutes, it looks like.
Hi, I'm Ann Grooms, and I'm a physician at the Student Healthcare Center. I'll let you see me. I'm not at work today. I'm on vacation. But we have a very, very good protocol treatment group for University of Florida students that's been in place for 5 years, started and promoted by a transgender female who came from Alabama to do women's study, and started a trans network that consisted of professors, community people, pharmacy, physician, nurses, mental health people, and over a year, we all worked to get the protocol that models after WPATH and UCSF and all of that. So those, we feel very, very comfortable. And one point is, I have a patient who just graduated who was started on her hormone therapy in your program. So she's from Tallahassee.
Oh, great.
That's
She's been
awesome.
on therapy for a year before she came to Florida. And she's done very well. And she's having her vaginoplasty this summer after
Great.
That's
graduation.
fantastic.
That is, we love to hear that. Interesting. I kind of wish that you would talk to my colleagues at the University Health Services here at FSU, because we actually get a lot of FSU undergraduate students who come to us because they don't feel that the University Health Services are providing the kind of care that you guys are doing. So,
Well,
kudos.
I would be happy to do that. I consider myself a champion that's out there for, because I feel it's so necessary. It's the most rewarding practice ever, because these people are so happy to have someone take care of them. And, you know, we're seeing 17, 18-year-olds and older, and they've never had access. A few have had access, but and they have families that don't support and do support and all that. But they're at a point where they can do what they want to do. We have Saudi Arabian who moved to the United States because she was transgender, wanted to learn, went to Atlanta to learn English, came to UF not even knowing what resources. She thought, I've got to get through my graduation, my master's work before I can get enough money to start my hormone therapy. And then she learned about us, the most ebullient, ecstatic woman, and getting her driver's license with her gender and her name was so important. one other comment, and if somebody else wants to jump in too. We have spent a lot of time sensitizing our staff about how to approach people and paying attention. And we ask the patient, do you want to be called your preferred name from the lobby, or do you want to be called your legal name? And and how do we transition into those pronouns? So we constantly ask them, and then we sensitize our staff, and they really work hard to be appropriate.
That's
And
great.
our secretaries, but it takes work,
That's great.
as you know.
Yes. One thing we didn't talk about, and your comments kind of made me think about that, is that I'm constantly amazed how, for our trans women, how a very low dose of estradiol, 2 milligrams, 1 or 2 milligrams in a month, where there's virtually no body habitus changes, they come back and emotionally and mentally they feel so much better. For many of them, it's like for the first time they see the sun and the flowers and everything like that. So it doesn't take much to sort of clear the mental issues that many of these folks have who've been living in the wrong body for so long.
And I think to the point that you were talking about working with the staff, I think it's very important when we do this workshops and teach others, is that being transgender does not mean looking a certain way. So if you're a transgender woman, that doesn't mean you have to look feminine, you have to have curves, you have to have the breast. It doesn't mean any of that. If you identify as a transgender woman, then you identify as a transgender woman. And the reason I say that is because it seems to me that often the improper pronouns is when a transgender woman doesn't look feminine enough. Mm-hmm. So then everyone gets flustered, and that's just not right, and it's not fair. So working with staff on make sure that you're using the proper pronouns that the patient's aligned with, period, outside of the look.
Right. And the non-binary patients, I try to sensitize them to the fact that you really do have to explain the pronoun you want to be used, because it's not like you look female or male. And so don't be offended if somebody uses the wrong pronoun because they didn't know that you want to be they or them or theirs. So
I was going to say, also, it's okay to make mistakes. We all do. We continue to do that. And if you make a mistake, you apologize to the patient. It still sounds a bit dissonant to me to call someone they.
Absolutely. It's not natural.
Right. And we do it. And if we make the mistake and we call them something else, then you just say you're sorry.
Right.
Right. Right. One of the best educational experiences I've had is going to some of the WPATH courses on feminization and masculinization surgery, and just the general courses. So anyone who has access to going to those courses, it's a tremendously helpful.
Hey, this is Jason Largent. I'm actually a family medicine doctor with St. Vincent's in Jacksonville residency program. And so we're just embarking on this journey. And so it was very reassuring to hear that pretty much everything you said is what I've been doing, because I fell into the point, I have not part of the community. I didn't know anything about it, but we kept getting patients. I was a resident here and now faculty for a few years. And I would just refer them to endocrine, and they would come back, and I would think, like, UF being here, that their endocrinologists would take them, but there was nobody in town that was treating adults. And as I realized that, we actually have 3 pediatricians doing kids, which is great because I don't want to touch that. But for the adult side, there's none. And so I just started working with them, developed, like you said, a word of mouth reputation. And so now we're partnered with a couple of things, and we're just growing it. But I'm actually giving a talk tomorrow for the Florida Academy of Family Physicians about transgender care. And so this was super reassuring, because I'm kind of coming out of a box, relying largely on UCSF websites and everything, like you said, and Fenway Institute. So I just wanted to thank you for a great talk. And it was helpful for someone who's hopefully in your position in a couple of years with the clinic that you guys have.
Well, good luck. That's great. Good for you. We send some of our students to the family medicine residency program, so you'll probably see some of our students there.
Yeah, no, we get plenty of medical students from FSU. We got a good pipeline. We always have a couple of residents And I think one of the faculty now is one of our recent graduates, Shamika Hogan Matthews over there.
Oh, yes,
Yeah.
Shamika,
Yeah,
sure.
so she's
We love
she's
her.
fantastic.
We're glad she's here.
Well, unfortunately, I think we have run out of time. So it's 1 o'clock now. I appreciate everybody joining us for this talk. Thank you. Please feel free or remember to evaluate this session to receive your CME credits. And we hope that we can get you guys involved with primary care innovations again. This was a great experience, a lot to learn for all of us. So, and thank you very much.
Thank you.
All right,
Thank
take
you.
care, guys.